If your blood is thinned, it may last longer, but I would say it's 90% of patients will have some blood in their urine after a biopsy.
Do they have some kind of medication that can thicken a natural urine? A cardiologist loves my blood.
Yeah.
Nobody else does when it comes to
Yeah.
surgery.
You don't want to thicken your blood if you can avoid it. Yeah. Yeah. Yes.
Are there certain factors that will determine whether you're going to have incontinence or not, or
Right.
the
Yeah.
level of it?
Yeah. So we do know that incontinence is multifactorial. It's technique related, but it also is patient related. Some patients have a shorter, what's called membranous urethra. So from the prostate, right next to the prostate is called the urethral sphincter mechanism. And that sphincter can be longer in certain patients and shorter in others. And the length of that sphincter has been shown in studies to really predict the chance of being dry after surgery. So, personally, I've done, I think, perfect operations to guys and they've leaked. And then there's guys that I know had a very short, and there were the guys I thought, well, I did a terrible operation and they were dry as a bone. So there are some patient factors that do influence continence. Yeah.
Which is better, long or short?
Long's always better.
Long.
I hate to come here to tell you that. No.
So does multiple biopsies cause any scarring that makes it any more difficult to remove
Right.
the prostate?
So this gets to the point of what we're doing with active surveillance now. So a lot of guys on active surveillance, which I think is good for certain patients, they can get multiple biopsies, and we have seen, so we've gone in on some of these guys that have had 4, 5, 6 biopsies, and it's not the same operation. It can be more difficult, the scarring, because every time you get a biopsy, there's a little bit of blood that usually gets outside the prostate, and that blood over time can cause scarring and fibrosis and can make the planes around the prostate much more difficult to separate. So I would say 2 or 3 biopsies probably not an issue, but when you get to the 4, 5, 6 biopsies, then you start to see people that have had, it makes the operation much more difficult.
So is it a longer operation or slower, or how does it affect?
Yeah, it's longer, but it's also, see, one of the things you're trying to do when you remove the prostate, in general, is you're trying to take the prostate out, but preserve the tissues around the prostate, which are important for urinary and sexual function. So that's the sphincter mechanism for urinary control, and then the nerve bundles that run along the side of the prostate for erectile function. These structures, when they get scarred and fibrosed, are very hard to separate, and that can make it more difficult to spare them safely. Yes?
Several years ago, I had a hernia, and then they put a mesh in there.
Yep.
Does that complicate the situation?
Where is your mesh? In the groin or in the belly button?
Belly button.
Yeah, so that can, believe it or not, so groin mesh, in my experience, has never stopped me from doing, and I've done a lot of people that have had hernia, groin hernia mesh. Believe it or not, umbilical hernia mesh has given me more trouble than anything else, and it's all dependent on how the surgeon put the mesh in place. I've had some people that have had hernia mesh for umbilical, and there's no problem. But the people that I've had problems with, and these are big problems. In fact, one guy I actually had to stop the operation because of it. When they put hernia mesh in, if they're not careful to make sure that the lining called the peritoneum is between the mesh and the bowel, the mesh is like a bowel magnet, and the bowel will stick up there. The small intestine will stick up there. And so you put the carbon dioxide in there, and you look in, and there's a segment of small bowel stuck to the mesh. Now, sometimes you can get it off, and sometimes you can't. And the patient I was describing to you, we couldn't get it off. Or we had to take a segment of his intestine to get it off. We had to reconnect his intestine back together. I did that in another patient, and he had a bowel leak a week afterwards. I had another patient, so when somebody tells me they've had a umbilical hernia mesh, my ears perk up. That's the only thing that is giving me trouble with regard to any kind of surgery. I've gone into guys that have had their colon completely removed, guys that have had, huge abdominal surgeries, gastric bypass. We've done the operation. We can take down the adhesions and we can get it done. But that little bit of umbilical hernia mesh, if it's not put in properly, it can stop the game.
How big a mesh do they normally put in there?
Usually for belly button, it's about I guess, it's probably like 2 by 2 centimeters, or maybe, I would say 2 inches by 2 inches. That's a common size.
So you can miss it, though, you don't go through that.
You try to avoid it, and you can go through, it's not a problem, but you can go above it usually. If we know it's a umbilical hernia mesh, commonly what we'll do, so the first port we put in is usually right near the belly button, because that's the highest point. But if somebody's had an umbilical hernia mesh, my first port will be low, and I'll look there first, because what you don't want to do, when that first port you put in, it can be blind. If you put it in blind, you could hit the bowel on your way in. That would be a problem. That does happen. So I put my first port in laterally, and then I look to see what's going on with the mesh. And then I put my other ports in, and I can miss the mesh that way.
Could you map the course with some kind of scan pre-op?
The mesh doesn't show up that well, and it won't show if there's any adhesion. Because on the scan, the bowels will be right close to it anyway. It's only when you create the space where we actually see where the adhesions are.
What if you have a hernia, I have a small hernia,
Yeah.
and they don't want to operate on it because of my age, according to the doctor?
What kind of hernia? Groin hernia? Or? Yeah. So I published a paper in, this is kind of related to your question, but it's not, but I published a paper in like 8 years ago. When we would take, when you do prostate surgery with the robot, or any prostate surgery, you actually move the bladder off the pubic bone to get to the prostate. You have to move the bladder out of the way. A lot of guys, if they have groin hernias, the bladders are actually stuck in there and they cover the hole. But when you move the bladder out, there's a hole there. It's a big hole sometimes. We learned the hard way, like about experience again, we learned the hard way that if you leave that hole not covered, the small bowel intestine can get stuck in there and people can have a bowel obstruction. And that happened to me twice. After the second time I said, no more. I'm not a general surgeon, but I can fix this hernia. So whenever we see a hernia now, at this surgery, we put a piece of mesh on the inside. And you can do it beautifully with the robot, and it works well. So I fix any hernia I see at the same time. As
Two for one.
I do the prostatectomy, 2 for 1. And a lot of guys don't know they have them. A lot of guys are they're silent hernias. Some guys do, they know, and we know we're going to fix it. But some guys have silent hernias, but I fix every one of them. Come on in, we'll get it done, yes.
Good job, Zach.
Do you have a checklist, like a pilot who gets ready to take off, you have a checklist?
Yeah, we do.
Would a mesh for a hernia be one of the things you'd see? Well, I know you have to inject that.
So checklist for me means that before the operation, we've checked all the things we needed to do a safe operation. So, we make sure we've got enough carbon dioxide. We make sure we've got the right instruments. We make sure that, the patient's been prepped sterilely. But I'm not sure what you mean by a checklist, but say your question again?
But anyway, when they were doing my robotic,
Yeah.
they put more holes in me than normal.
Okay,
Because they were going through the mesh and they cut themselves.
okay,
So they had to come back out and go over here and
right,
do it on this side.
yeah. Well, I would say this, that the amount of mesh and the size that people put in can vary. Okay, so it's not, it's easy. You could go through the mesh. There's no question about that. I don't think that's a game changer. I still think you can do the operation. You don't necessarily have to fix it. It should heal up. But I'm not so sure kind of what happened to them. But I would say, yes, you can go through the mesh because the mesh can be much bigger in certain cases.
Well, they knew about the mesh.
Yeah.
It was in my medical record.
Right.
So I don't know why they.
But they may not have known the exact size of the
They
mesh.
took it back out and they moved it over.
Yeah,
So I've had multiple incisions, so.
yeah,
And the biggest one is the one above the belly button. I'm
Yeah.
sure that's where they pulled the
Yeah.
prostate out.
you had it robotically.
Yeah,
Oh, good for you.
yeah, it was successful actually.
Yeah,
In 6 weeks after the surgery, I quit urinating.
you got your confidence back.
I
Wonderful.
got my
Good for
confidence
you.
back.
Good for you.
So I was,
Congratulations. Yeah, that's great.
because that is the most horrid thing you could ever have.
Yeah, it is.
Doctor, I've got a question on
Sure.
mesh. I saw on television a while back where it was mainly women that their mesh they had in their body was deteriorating
Mm-hmm.
and it was causing severe illnesses and
Mhm.
possible death. Do
Mhm.
you know anything about that?
Well, that's a common, well, I see it now on commercials for lawyers for the most
Yeah.
part.
Yes.
So the story behind that mesh, and this is a different mesh than what we're talking about.
Okay.
There's a mesh that women will be placed in women to lift up the urethra, the female urethra, to prevent incontinence. It's a sling procedure. And they've used the mesh And this mesh sometimes can erode into the urethra, and it can cause infections, and it can cause leakage, and people can get sick, and it can be removed. But there's certain types of mesh that have caused problems, and now it's become like a cottage industry for the lawyers, and they're making as much money while they can, on this. So that's the female mesh, a little different than the mesh we're talking about.
Okay.
Yeah. Yes, please.
The driving, can that be a problem? I do a lot of long distance driving for inflamed prostate. He was mentioning driving.
Driving, you mean, so we're talking about prostate infection now?
Well, yeah, I have an infection. I just drove back from Alaska, so I was kind of,
That's
nothing
great.
consistent with that.
They have airplanes, but I don't know if you know they're not. You know, I'm not sure about sitting. I mean, I haven't really seen that as being a risk factor for infection. I mean, there's other things that can give you, that, but I mean, I guess you're gonna notice it a lot if you're sitting on it. That's one thing for sure. I'm not so sure it's gonna make things worse, but, prostate infections are extremely difficult to treat. They're long-term infections. They take long courses of antibiotics. You shouldn't treat a prostate infection with anything less than a month of antibiotics. If you've got less than a month of antibiotics, you're inadequately treating the infection. And you may need multiple courses of antibiotics for prostate infections. They're very difficult to clear. Yeah. Yes, please, Mark.
May I make a comment? I'm sorry about my voice. I have allergies to my dog, and I'm getting the shots for him. But anyway, 8 years ago, I was diagnosed with an elevating PSA, and I went to a local urologist in Tacoma. He wanted to do the open procedure immediately. Well, that raised a red flag. I'm a retired podiatrist, so I have some medical background. Nowhere near what Dr. Porter has. But it alerted me. And anyway, my comments go this way. Dr. Porter did my surgery. I went to see him after researching him, and that is the key. Look up the person you're going to. See how many procedures he did. Dr. Porter had a high number of procedures. I think it was a little over 1,000 at that time. And I read the reviews on him. I called a few other physicians, asked about him, I checked up on him, and he was the person that I had the most trust in. And I went and had the procedure, and 7 years later now, I'm fine. I had no urinary incontinence, I had almost no pain. I got up the next day, and well, that evening after surgery, and walked, and we walked through the hospital tours. I went home the next day. I mean, I'm fine except for one thing. I didn't listen to Dr. Porter. He said to me, you have one positive node. And I thought, well, I'm smart. I have researched this. I'm a doctor. I know everything. Well, I guess I do. But anyway, I figured if I can beat the odds, because every time I would go and see Dr. Porter, my PSA was negligible, 0.0 something. And I thought I could beat the odds. And by now, 7 years later, maybe they would have something that would be more modern and more up to date for treating. Because now my PSA has been doubling every 6 months. Because I didn't follow his suggestion to see his oncologist friend. And I have to make a decision what to do next. But anyway, the key to all of it is research all of this. Find out you have a physician who's got the experience. And I don't mean to, overstate this, but Dr. Porter's got the experience.
Can I ask you something?
Sure.
You said that your PSA started going up how far after surgery?
Oh, it was probably 3 or 4 years, just the last year or two.
Is that unusual?
Well, to have a positive node and get that kind of durable, that's really actually unusual. It's actually very good. Most people with positive nodes have their PSA come back quite quickly. So he actually had a pretty long interval with the PSA not being detectable. That actually predicts a pretty good outcome. And he could still see the medical oncologist and still be treated and still be okay. But most of the time when you have a positive node, it means there's probably disease elsewhere. He clearly had disease elsewhere because it's coming back, but he didn't have a lot. So I mean, I think you did the right thing for a long time, and you still have these treatments available to you, so I think you're gonna be fine.
I'd like to ask you one more thing, if I could. When I had my prostate problem, I had a nodule on it, and it forced me to act quickly. What would have happened if that would have broke out of there?
Well, the nodule wouldn't break out, but what it means is that you have, most cancers that we diagnose now are diagnosed based on the PSA elevation. That's at stage 1. When you have a nodule, it puts you into a stage 2 prostate cancer. And that means there's a higher chance that there could be cancer outside the prostate. So acting on it quickly is good. Breaking out, maybe what you mean is, when could it have gotten outside the prostate? That's what we can't predict. So when you have a nodule, when I have a patient with a nodule, I'm going to do a more thorough cancer operation, meaning I'm going to take as much tissue as I can where the nodule is, because if any cells have gotten outside there, kind of what you're saying by breaking out, I want to be able to encompass those cells and get rid of them.
Well, what, if it comes out, it's not necessarily going to do any harm, or would it?
Well, it could stay in your body, and then it could come back and grow later, and you'd have to deal with it in the future.
Yeah. Okay,
Yeah.
Bill's, yeah, one more.
Yeah.
It was just kind of a follow-up to what you were saying, and going back to what you said about studying the nomograms and,
Yeah.
and involvement
The lymph nodes.
of the lymph nodes.
Yeah.
When you, with your patients in your practice, I mean, do you have discussions with them about that? And it sounds like you do.
Yeah.
That is the question I was gonna ask.
That's part of the pre-op.
Yeah, we talk about the nomogram, we talk about why I'm doing the lymph node dissection, because I don't do it in everyone, but clearly, you know, he had the risk factors for it, and that's, he had a positive node, so, yeah, we talk about nomograms in all my patients.
Last question.
Please.
What was your experience like for your first operation?
Good question. That was on him, the one he told us about.
So the first operation you do is in your training. You know, you're doing that with a senior person above you.
I would hope so.
And, yeah, and, you know, you're kind of just, well, I'll tell you the story of the first surgery I ever saw, which was, I was a medical student. And I remember, and this is in Toledo, Ohio, I'm from Toledo, and I'm at Toledo Hospital, and they opened this patient up, and I'm standing there, and I'm scrubbed, but I'm not allowed to touch anything. I could just use my eyes. And I look down, and I see this, and I fall backwards and pass out. And it's a miracle that I'm a surgeon. You know? You know, but that was when you see something like that for the first time, it's otherworldly. You know, you can't even,
a lot of blood.
Amazing, you can't even imagine what it is, but now, you know, it's common. But, you know, my first surgeries, you know, it's really, there's so much information you're trying to take in. You know, you have no idea really how to move your hands in space. You know, there's so many things about surgery which just are not normal. You know, I mean, you're putting holes in somebody. You're basically committing assault legally. You know, when you do surgery. Okay, and I'll kind of leave you with what a mentor taught me about surgery, and I pass this on to all my trainees. But one of the mentors I did surgery with, for the first time, he said, "What's the most important surgical instrument?" And I said, "My hand." He said, "No, your brain." He said, "What's the second most important surgical instrument?" I said, "My hand." He said, "No, your eyes." And he said, "What's the third most important surgical instrument?" I said, "I don't know." And I said, "Your hands." So it's brain, eyes, surgeon, eyes, and hands in that order. Okay.
Now,
Your surgeon has to be a good thinker.
Is that first experience counted among your 3,000?
No, the 3,000 is my experience. Actually, it's Swedish.
Okay.
Not counting what I did at UW before. So that's just starting at Swedish in 2005.
Thank you.
Yeah. Yeah.
Thank you very much. Unfortunately, no money in there.
Don't worry about it. No money. Thank you so much, you guys.